Okay. Respected principal, sir, and distinguished speaker of today's online special lecture program, faculty members, and my dear students, a very good evening to all of you. It gives me immense pleasure to welcome you all in this online special lecture program organized by Department of Economics, Department of Commerce, and Department of BBA. First of all, I would like to introduce our invited resource person of this online special lecture program. As a guest speaker, today we have with us Dr. Amlan Majumder, Associate Professor and presently the head of the Department of Economics, University of North Bengal. On behalf of Behar College and the organizing departments, share gratitude for accepting our invitation. Thank you, sir, for sparing time from your busy schedule to grace the special lecture program. Topic of today's special lecture is very relevant. On our limited healthcare resources, and it has shown us the lacuna of existing healthcare system. So, in one hand, we have realized the increased demand with limited resources so that we can get maximum satisfaction. These type of issues compel the policymakers to think about
Shubham, network issues, probably.
subject matter of special branch of economics. Hello?
Yes, continue, please. But
Okay, sir. Okay. So this type of issue compel the policymakers to think about efficient use of healthcare resources, which are very necessary to get maximum satisfaction, and how these limited resources can be utilized efficiently to maximize the satisfaction level is a subject matter of a special branch of economics. So I think, in my opinion, this makes the topic which is selected for today's special lecture program, that is economics of health and healthcare, as more relevant and timely, depending on the current situation. So today we have our Honorable Principal Sir with us. Now I would like to request our Principal Sir to say a few words for the participants. Principal Sir. Principal Sir.
Suman.
Okay, Principal Sir is now with us. Yes, Principal Sir is now with us, so I would like to request our Honorable Principal Sir to say a few words for the participants.
So, good afternoon to all of you present here. Today, the Department of Economics and Department of Commerce along with Department of BBA have organized an online special lecture. The lecture will be presented by Dr. Amlan Majumder, who is the Associate Professor and now Head of Department of Economics, University of North Bengal. Dr. Majumder will speak on the topic Economics of Health and Healthcare. I think that this is a very current topic, and as we have been passing on this COVID-19 situation, so I think that today's presentation will highlight the health issues and especially the healthcare that is post-COVID situation, and the students and also for the teachers who are attending this online special lecture, they will be benefited much from this lecture, and especially students are advised to interact with our speaker so that you may communicate with him regarding any query, any doubt. So I think Dr. Majumdar will definitely help you in this regard. I think today's session will be a very successful one. From my side, I want to thank all the faculties of these three departments, Department of Economics, Department of Commerce, and Department of BBA for organizing such a very important and current webinar on current and important issues, and selecting a special person who is also very expert in this particular field. And Dr. Amlan Majumder is very well known to all of us, and he was for long years in Behar College, and now he is acting as head of the Department of Economics. So, from all the members of our Behar College, I want to thank and convey our heartiest congratulations to Dr. Amlan Majumder for accepting our request and to deliver a lecture on such an important topic. So no more today from my side. Over to Sushovan. Sushovan, please.
Online webinar of Department of Higher Education, Government of West Bengal, which is scheduled in a very short notice and going on now in parallel to this program. So Abhijit sir has sent his best wishes for success of this special. University of North Bengal. Prior to this, he has worked as an assistant professor of economics at Behar College for more than 17 years. He obtained MA and PhD in economics from the University of North. The University of Pavia, Italy, and the Chinese Academy of Social Sciences, Beijing. He has also been a visiting researcher at Kansai University, Osaka, Japan, with a postdoctoral fellowship from a Japan Society for the Promotion of Science. He has been nominated as CIC OPS Fellow from the Center for International Cooperation and Development, University of Pavia, Italy. His research interests include economics of healthcare utilization, measurement issues with economic inequality and human development, and environmental ethics. His papers have been published in numerous national and international journals of review. So this was all about a very brief introduction of our today's speaker. Now, before handing over the mic to our guest speaker, I would like to request our participants that if you have or if you want to ask any question regarding today's lecture, then please use the chat box. In the question answer session, there will be a question answer session just after the lecture, and in the question answer session, the relevant question will be transferred to our speaker. And after the question answer session, a Google Form link will be shared in the chat box to record your attendance and valuable feedback. With this, I would also request the participants that please make sure that your mic and video both are in off position. I will not take much of your time, and I am very hopeful that this lecture will be productive and very interesting. Now, I would like to request our today's speaker to deliver his lecture. Amlan sir.
yes, thanks, respected Chairperson, Chairman, Dr. Pankaj Devnath, Principal, Behar College, and my dear Pankaj Da. I am known to him as a younger brother. He treats me as a younger brother for more than 20 years. We've been in contact, and he has been, now I think he is the only person to act as, to guide me, or he's the person from where I can take honest guidance after the sudden demise of our previous principal of our college, Dr. Sadhan Chandra Kaur. Now, I was thinking about that now Pankaj remains as the only person who can guide us. And he's taking care of us for more than 20 years, as I said, even maybe more than that. So I'm thankful to Pankaj Da and other faculty.
Thank you, Amlan.
Thanks to all other faculty members and participants. Although nowadays I am very busy and a little bit I'm doing administrative works, so a little bit away from academic activities, you can say. But I have decided to speak on economics of health and healthcare because these are the issues which are being discussed very prominently nowadays. And considering your background, I have decided to speak on the very basic issues and concepts so that you can easily understand that how we can apply economic tools to solve the problems associated with our health and well-being. So let me now start my presentation. Let me open my presentation. Is it visible?
Yes, sir, it is visible, sir.
Visible, huh?
Yes, yes, yeah.
So, I'll be speaking on economics of health and healthcare. And the lecture is organized in this way. First of all, we will speak on or we will understand the concept of health, definition of health. Then the operationalization of the concept of health. Because the definition is conceptual. we can understand everything from the definition, but it is very difficult to quantify it. So after defining health, we will explore the possibilities of operationalizing it, the concept of health. Then we'll come to the 4 forms of morbidity. The term morbidity is nowadays widely used. You have heard about comorbidity. So morbidity will define the concept, and some other important concepts such as global burden of disease. So we'll look into it, its classifications. Then how economic development is related to changes in health status. This is one part associated with the term health. Then we will define healthcare. Look, these 2 concepts are not same. One is health and then healthcare. Then we'll look into the theoretical framework on healthcare. So economists consider health service sector as industry. We'll discuss about that. Then we'll go to the supply side and demand side economics of healthcare, how we can apply economic tools to the problems associated with healthcare. Then mixed demand supply framework of studying utilization of care. We'll briefly define or talk about healthcare system in India. And if time permits, I can talk about some empirical studies in the supply side economics of healthcare. Now let me begin. With the definition of health. There are various definitions, but the accepted definition or widely used definition was given by World Health Organization in 1946. According to that, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. It's a complete physical, mental, and social well-being. So it measures well-being in 3 different dimensions: physical, mental, and social well-being in these 3 directions. So as I said earlier, that it is a conceptual definition. The definition is very good. It makes a sense to us. But as a student of economics, if we try to measure health, then there are lots of questions. How to quantify health? How to measure health? In reality, health is measured by the degree of ill health. So from the opposite side, we start not from health, but from ill health. Now, ill health is termed as morbidity, which the term gained popularity during this COVID situation, comorbidity, morbidity. So morbidity actually ill health, the state of ill health, meaning the state of illness or disability in a population. It is a departure from the perfect health condition. If one person is in the perfect health condition, so we may consider it's a good health, but ill health is a departure from that state. So in this context, we know that death is a clearly well-defined event. Death is a clearly defined. We know what is death. But illness is not. Illness is not. It is not well-defined. But we understand that it is a state somewhere between perfect health and death. In one side we have death, and in one side we have perfect health. So illness may vary in between. And it depends upon the criteria used to measure it or to observe it. So let us now move to the measures, that how experts, economists, social scientists, they applied their mind to measure health or morbidity. As I told you that we cannot measure health. Obviously we can measure, but we have to ask you, that are you in a good condition? Yes. Are you fine? I am fine. But maybe it is not the perfect condition, because maybe he or she maybe not knowing his perfect condition. So we are not measuring health, but we are measuring morbidity. So morbidity measures are of two types. One is self-perceived morbidity, and the other is observed morbidity. Observed morbidity is something that when we visit a clinic, we go to a doctor, or even you may observe me whether I am in morbid condition or not. For example, I have cough and cold and I am not feeling well. You may observe me. This is one kind of measure. Another is self-perceived morbidity. I may say that I am not feeling well. I may say that I have pain in the abdomen. But if I go to a doctor, then it may be diagnosed as a disease or something. So in economics and in most of the fields of social science, morbidity is measured through self-perceived morbidity method. In this lecture, we also discuss about self-perceived morbidity method. So how it is measured? For example, say we are visiting or surveying one area, locality. We may select some households and we may ask persons that, did you experience any kind of symptom or any kind of illness, say within 1 month or say within 6 months or in last 1 year? We may ask such questions. And one may report that, yes, I had a fever, I had headache, I had this and that. Even they may report some specific diseases which were diagnosed by medical professionals. So through this method, we visit households or we conduct surveys to gather data on morbidity. We simply ask our respondents and we note down whatever they're responding in their vocabulary, in their words, not according to our understanding. Someone is reporting, say, chest pain. So I should not write that it is a respiratory or cardiovascular, any problem related to cardiovascular disease or etc. As they are reporting, we are taking. Then we will do classification and we will go for that. Now, Murray and Chen, they did one seminal work in 1992. And they grouped self-perceived morbidity method into 4 categories. As I explained just now, the symptoms and impairments, we may report that I had cough and cold, I had this and that. It will come under the first point, symptoms and impairments. Second one is functional disability. You might have noticed while visiting a survey, while visiting a locality, that some persons, they are unable to perform their regular works or regular duties. They are functionally disabled. They will come under the second category. And the third term, handicap. Although nowadays the vocabulary changed, we say differently abled, but Murray and Chen in 1992 used this term. That's why we did not change it. We did not change it. Handicap. So we can observe. Or one may report. And the fourth one is health service use. If we visit one health facility and if we ask to show records of the patients who have visited, we may get one rough idea that in this locality, how many persons have suffered from some kind of diseases or any kind of impairments. But the fourth category is good for developed countries where people are more concerned, where recorded are very authentic and regularly kept. In our country, people even do not report that they have any problem. Even they may not utilize health facilities. So data on health service use, it is good for European and American or other industrialized countries. So mostly the researchers in economics, in the field of economics, we consider these three and mostly the first one. The morbidity surveys are found to be dependent upon the perception and reporting. I have already told you. And for most of the developing countries, when we analyze or get morbidity data, they are based on the first method only. So I am sharing with you some data. This is based on one minor research project which I have completed while I was at Behar College. So it was a study in the forest villages and tea gardens in the Dwarf region. Now it is in the Alipurduar district. Earlier it was a subdivision. There we have done the same thing. We have asked the tea plantation workers and the forest villagers that have you suffered from any kind of disease in past 1 year, or a reference period I do not remember. Maybe it was 6 months or 1 year. So they have reported that yes, I had cough and this and malaria and this and that. So just imagine if we cover 100 or 1,000, say 1,000 persons, one may suffer say 5-6 types of symptoms in 1 year. So in total, we may have 5,000-6,000 responses. So how to read that? How to classify that? Now, on this context, this phrase is very important, global burden of disease. If you Google it, you will find that global burden of disease study. There is a platform. It is run mostly from the Johns Hopkins University, United States. A group of researchers are involved in it. They have classified diseases into 3 categories, or symptoms in 3 categories, or even you can say the causes of morbidity or causes of death. Mainly they have classified according to causes of death, but in the context of developing countries or India, causes of death statistics is very limited. So we are using the same concept for morbidity, illness. They have classified in 3 groups, 1, 2, and 3. In 1, communicable, maternal, perinatal, and nutritional conditions. Mostly communicable and related to maternal health care. Those will come under the first category. Infectious and parasitic diseases, respiratory infections, maternal conditions, etc., etc. Nutritional deficiencies, etc. Group 2, non-communicable diseases. Here you can see the cancer, belly-gland neoplasms, other neoplasms, diabetes, all these lifestyle-related diseases, diabetes, cardiovascular diseases, neurological conditions, all will come under this category 2. And group 3. Then group 3, injuries, intentional and unintentional injuries. So I am presenting this table for 2 purposes, that we can see the classification of diseases as well as it has one empirical part, that it is based on my survey. So what we have done, we got some results I can share with you, that 51% of the persons we covered, they reported in the forest villages. Yes, of course, it is in the forest villages that they suffer from communicable and this group 1 symptoms and diseases. 51, more than half of the people, they are suffering from infectious and all these diseases. Do you know infectious and parasitic diseases, Major? cholera, diarrhea, etc., malaria. Non-communicable, all lifestyle-related diseases, diabetes, cardiovascular diseases, neurological disorders, mental problems. So 46, nearly 46, they suffer from this kind of disease. Only 2.4% they suffer from intentional and unintentional injuries. So any kind of accidents, all those will come under the third category. Now, if we look at the results from the tea plantation areas, so forest villagers, they do not work under any industry. As you might have known, or you may have come across the concepts of forest villages in North Bengal. So there are some settlements inside the forests. So people used to live there. They have a small plot of land to cultivate. They have small huts. They live there. They work for the forest. They also cultivate, but they do not work in industry or else. So their livelihood depends upon the forests only. But in contrast to that, we have tea plantation areas in North Bengal, tea gardens. Tea garden is on industry, it comes under industry. So in industrial setup, less than 50%, slightly less than 50%, they are suffering from communicable diseases. And then 40%, 46%, they suffer from lifestyle-related diseases. And nearly 5% from the injuries. So as they work under industry with machines, etc., so their suffering with the injuries is higher. So this is just one example of that how we can use these concepts to classify our morbidity data. Now let's move to the next section. Yes. So in this section, we will define economic development and change in health status. So let me move to the previous slide. So when global burden of disease, they have classified 3 categories. They had something in mind. The classification has not been done very arbitrarily. It is linked with economic development. Let me explain. As you are all undergraduate students, may I ask you that have you come across the term demographic transition? I cannot see the screen because I am using the full screen. Have you come across the term demographic transition? Okay, let me explain. Is my screen visible?
Yes, sir. Yes, sir.
Yes, sir.
So the concept of demographic transition says that when a country transforms itself from an agrarian one to an industrialized one, with economic transition, demographic transition also takes place. When a country transforms itself from an agrarian one to an industrialized one, with economic transition, demographic transition also takes place. What is demographic transition? It is a transformation from high mortality, high fertility situation to a low mortality, low fertility situation. Consider the year 1900, long back, more than 100 years ago. Consider the societies in India or in the subcontinent. High fertility, high mortality. So how high could be fertility? If we take crude birth rate, then it may be around 40 or like that per thousand. High mortality. So death rate was also around 40 per thousand. So just consider that birth rate was a little bit higher, 42 or 41, and death rate was 40 per thousand. So what will be the result? Birth rate, death rate was almost same. So growth rate of population was very low. And most of the people may be suffering from cholera, diarrhea, malaria, etc., etc., etc. Health condition was very poor. So, in a country, before the demographic transition, health condition was very poor. Now what happened in between? In between, because of economic development, because of development of immunization, development of healthcare, many different innovation. For all this, death rate has come down very sharply. Death rate has come down. But birth rate has not come down. So the difference was, say, very high. Say death rate has come down to birth rate, death rate has come down. Do you know what is the present death rate on an average? Any rough idea? Per thousand? In Indian societies? Maybe it is 6 or 7. Say from 42, it has come down to 6 and 7. Still, birth rate is, say, little bit high. How much? Maybe 13, 14, 15 per thousand. So there is a difference. And that difference is the addition to the population, the size of population. But when demographic transition takes place, then both birth rate and death rate again come down to the almost same place. So in near future, our birth rate and death rate will be around 6 or 7 like that. So what will happen? Again, population will not increase. And what will be the health condition? As death rate is very low, people are not dying, it implies that health condition is very good. So before demographic transition, health condition was very poor. And after demographic transition, the health condition will be very high or very good. Using this concept, Amlan in 1971, Abdul Amlan in 1971 introduced a concept, epidemiological transition. Mind that, earlier we used the term demographic transition. Now, in studies of health, they introduced the term epidemiological transition. Now, please relate it with the demographic transition. That when a country transforms itself from an agrarian one to an industrialized one, with economic transition, pattern of disease also changes. Yes, this is true. In an agrarian society, a country where industrialization is very low, the country's economy is mostly based on agriculture and allied activities, people suffer mostly from infectious diseases, cholera, diarrhea, etc. Maternal conditions, that is birth rate is very high, maternal death is very high, nutritional deficiencies, malnutrition, etc. All these dominate. So, before the economic transition, group 1 type of diseases dominate. Then, with industrialization, when industrialization starts, then the disease pattern changes. If you now conduct a survey in the Cooch town, if you ask people that did you suffer from any kind of problem in past 1 month or past 1 year, mostly people will respond that report that diabetes, issues related to chest or heart, or all these lifestyle related diseases. So with industrialization, the lifestyle related diseases, those predominate. Now in the third category, remember that we told that after economic transition, it means that a country is very highly industrially developed, or even in the post-transitional stage, very high. Consider the case of Japan. So economic development took place long back, and now the country is in the post-transitional stage. Everything is very sophisticated. Still, they are suffering from intentional and unintentional injuries because the suicidal rate is very high in Japan or in industrialized societies. So it will come under intentional injury. Do you understand that how this classification is done? It is related to explain the economic development of a country. But in Indian context, if you do a survey, you will find mixed results. That nearly 50% is suffering from infectious diseases and the rest are suffering from non-communicable diseases. Here, you need to look at the state of healthcare. So far, we were discussing health. Now, just see, we need to look at the healthcare. Whether our existing healthcare system will be able to address these two major categories. Obviously, now we are suffering from COVID. It is infectious. But time will decide that where to put the COVID-19. I am asking you people, just decide. Will you put it COVID-19 in the group 1 or group 2? Let me share your opinion at the end. And in India, in most of the states, in towns and cities, if you see report, then India has a mixed kind of data. Nearly half they are suffering from infectious diseases, and nearly half or more than half suffering from lifestyle related diseases. So if you, mostly the public healthcare system was developed to treat mostly the group 1 type of diseases or conditions. And gradually now they need to develop, need to equip themselves so that with modernized equipment, so that they can address the issues related to non-communicable diseases, cardiovascular diseases, neurological conditions. So if you now use the term burden of disease, so India has a double burden of disease. Why? The burden of non-communicable diseases and burden of communicable diseases. Injuries is also high. You can, every day you can hear about road accidents, etc., and many other sad news. But these two are very prominent, group 1 and group 2. So burden of disease, you can measure burden of disease from these classifications. If you find that the percentage is higher in this category, you can say the burden of communicable disease is high in this context. So what we have discussed in the first half of the lecture, we have defined the concept of health, that it is a complete physical, mental and social well-being, and not merely the absence of disease or infirmity. And as you understood that it's a conceptual definition, in order to measure health, we need to start from ill health, not from health. Ill health, because it is easy to define. What is ill health? It is a condition between perfect health and death, in between. And Marian Chen and other, I have just mentioned one here, but there are some other scholars, Marian Lopez, they have also studied in these seminal studies. They have also done some seminal studies. It means the very important studies. And they have categorized the morbidity surveys in 4 categories based on symptoms and impairments, and then functionally disabled, functional disability, and then handicap or differently able, that category, and health service use. And of these 4, we use, the first one is most important for us, for students of economics and social sciences. And based on that, we may collect data on these categories as displayed in the table, and we may classify, and we may relate it with the concepts of demographic transition and epidemiological transition and economic development. So up to this, I think it is clear that in a developing country, the burden of both non-communicable and communicable diseases are very high. If you visit any industrialized country or very highly industrialized countries such as Europe, in America, or countries like Japan, you'll find that they have burden in the second and third category, group 2 and group 3. Now, by looking at this as a student of economics or as a researcher of economics, and you students will think that if this is the situation, then how can we treat these health or morbid conditions? Here comes the concept of healthcare. We will now move to the healthcare after defining the concept of health and its relationship with economic development. So now we will define the concept of healthcare from the perspective of economics. As you know, the supply and demand, these are the most important parts in economics concepts. We understand that here we need to define the need and demand. Healthcare is needed. I need healthcare. There is no question about it. You need healthcare. One mother needs healthcare. There is no question about it. But the question is whether it is demanded. Did I demand? Did I visit? Did I ask anybody that give me some care? So economists look the problem of healthcare in this way. Need is there, but whether it is demanded. If it is demanded, then only we can relate it with the supply of healthcare and other issues. So there are some remarks here, theoretical one. And one thing you should know that the market for healthcare is not a market as we find in case of other commodities. Because when I am demanding healthcare, I am utilizing healthcare, maybe I am not in a conscious state. Doctor is defining, doctor is advising me that you need to take injection, not the pills or tablets. Doctor is advising me, you go for this test, and I do not have any other option. I do not have any choice. Students of economics, you know that consumers' choice theory, utility maximization, consumer choose certain commodities from the market according to or in order to satisfy their well-being. But in case of health, we do not have any option. Option is there, I will discuss later, but whatever doctor will prescribe, we have to consume it. So in true sense, the market for healthcare doesn't exist. It is a different kind of market. And health is not tradable, but healthcare is tradable. It means you can purchase healthcare, but you cannot sell your health. Students of economics, you have these basic ideas. Now let me go to the theoretical background of health service sector. Now, from around 1950s, the economists began to turn their attention to the allocation of resources in health service sector. But at that time, there was no consensus of applying economic tools, either positive or normative. No, there was no consensus for application of positive economic tools. You might have heard these terms, positive economics and normative economics. Normative economics means you have to do some judgment. You cannot quantify it. But in case of positive economics, it is based on some economic tools. You can quantify, you can measure demand, you can measure supply like that. So Fuchs in 1966 published one article at that time in American Economic Review that titled contribution of health sector to the American economy, and it became very famous. Why? Because Fuchs, for the first time, considered health service sector as healthcare industry. Now, what is an industry? We know that one industry utilizes different inputs and produces outputs. What are the outputs of healthcare industry? You know it well. Medical services. We utilize services. This may be new to you. Hospitality or hotel services. Yes. When we take admission to any hospital, we utilize bed, we utilize food, we utilize fan, we utilize washrooms, etc., etc. So hospitality services is also important, is associated with this, with all these medical services. And validation services. These three are the output of the healthcare industry. Now, what is validation services? I am fine, you are fine. But in order to join your college, you need a health certificate. You need one health certificate. You are fine. You do not have any illness or morbidity. But just to secure your admission or say secure your job, you need a certificate that you are in good health. So that is validation services. Is there any other service that one healthcare industry produces? Can you suggest one anymore except these three? Anyone? In one presentation, one student suggested that, say, consider one hospital or super specialty hospital or any hospital. Through their practice and experiences, they may suggest one new technique, new method of treatment. For example, in case of COVID, you have found that many new methods came through practices. Nobody was aware, not medical specialists, they were aware of this mode of treatment. Through practice only, they discovered that, oh, this may work well. So research and development, that may be added with these three. So if you do research in healthcare and if you contribute one new dimension, then you will become famous. So I am asking you, my objective of this lecture, not only to define some concepts, I am making the field experience so that you develop interest in studies of healthcare and you later, after completing your graduation, you come to the University of North Bengal or any university, you study health economics and then continue your PhD. Do you understand? So we teachers move with long-term plan. And my blessings will always remain with you. So continue. Now these services are healthcare industry, are the services or output of the healthcare industry. How do we measure it? We may measure through number of cases treated or hospital admission, etc. If we go to any hospital or any health center or any nursing home or private hospital, we can count the number of cases treated. There are IPD and OPD, outpatient department, inpatient department, hospital admissions. We may count that how many patients were treated, how many cases were treated. This will be the output. This will be one measure of output of healthcare industry. What are the inputs to the healthcare industry? Fuchs defined inputs in three categories. Labor input. Labor input means medical staff. It is doctors, specialists. Paramedical staff, nurses, midwives, etc., etc. Labor input. Ignore this bracket. Then physical capital. It means plant and equipment. That is the building. Equipment means X-ray machine, ECG machine. ICU units. So all these will come under the plant and equipment category. And intermediate goods and services, say drugs and bandages, etc. So one healthcare industry, or if you consider one unit, just one hospital, just imagine, doctors are working, paramedical staff are working. So these are all the inputs to the industry. There are plants and equipments, that is building, infrastructure, machines, etc. And then drugs and services, goods and services. It means that all the drugs. Now remember, in health economics, by drug we mean that tablets, capsules, and injections, etc., etc. But in colloquial, in our everyday term, we say medicine. But medicine is not. I will explain that term. We say drugs. So intermediate goods and services means drugs and bandages, etc. Saline, etc., etc. So all these are input to the healthcare industry, say in one hospital, and output is how many patients are treated. So this kind of framework was given by Fuchs in 1966. And students of economics and maybe the BBA and commerce, I'm not sure about commerce and BBA, but students of economics, you have heard about Cobb-Douglas production function. Have you heard about it? Yes, obviously. So using the framework which has been proposed by Fuchs in 1966, one British economist, Feldstein, in 1967, he just estimated Cobb-Douglas type production function for British National Health Service. You have studied Cobb-Douglas production function in your production, the chapter of production or producer behavior or theory of production in microeconomics. A is equal to, say, one constant, or say Q is equal to A dot L to the power alpha K to the power beta. This is the standard form of Cobb-Douglas production function. Why Feldstein used Cobb-Douglas production function? Just to get the elasticity coefficients. So if the percentage of doctors is increased by this percent, to what extent, to what percentage change will come in the output, that is number of cases treated. So it was a very, very big kind of contribution to the British National Health Service for planning of the healthcare. So Feldstein became famous in 1967, and he became the pioneer person by estimating a Cobb-Douglas type production function, considering one on hospital or health service sector as healthcare industry. And he opened new avenues of research, and many researchers till now estimate Cobb-Douglas type production function using economic or econometric tools to explain the relationship between input and output. If doctors have changed this percentage, this much, then how much change will come in the output? If paramedical staff is changed, then how much change will come in the output from this context? Now, as you remember, I told you that I will define the frameworks in the supply side and demand side. In the Cobb-Douglas production function, what are the inputs? Doctors, paramedical staff, and equipments, machines, etc. All these are in the supply side. What is available in front of us? So the study of Feldstein and this framework is based on supply side economics of healthcare. Do you understand? All the inputs we used are on the supply side. What government is supplying, or what the private supply is there. Whether doctor is available in the hospitals, public hospitals, whether nurse is available in the public hospitals, whether drugs are available. So from the side of availability, from the supply side. So this is a framework of supply side economics of healthcare. What is there in the demand side? Obviously, today nearly 27 or 25 students you have attended. I have not seen the last figure because I am unable to go to that page. Do you think that demand for health is same for all of us? Obviously not. First of all, it varies according to gender. Huh? If someone is male, then he has different kind of demand for healthcare. If someone is female, then she has different kind of demand for healthcare. Children, infants, they have different demand for healthcare. Aged one, persons like me, middle-aged persons, we have different demand for healthcare. So in that function or Cobb-Douglas production function, if you consider factors like age, gender, the demographic factors, then it will be a mixed demand supply framework because you are considering both factors from both the supply side and demand side. And what is the most important factor in the demand side? Affordability, whether I can afford. How you can measure the affordability of a person or a household? Yes, during the survey, you have to ask or you have to measure the income condition of the household. In our society nowadays, people depend upon their cash income. Even they sell their domestic animals. They cut down, chop down trees and sell for healthcare. They take loan. Very few, they depend upon insurance to finance healthcare. So economic condition of the persons, of the households or of the patients is also a very important factor from the demand side. If I can afford, then only I can demand. Otherwise, how is it possible? How will it be possible? So these are some of the issues, some of the studies. If you ask, then I may share these slides. You will get some idea. You can then you can go through these studies if you are interested. Shushovan, should I continue?
Yes, sir.
Huh?
Yes, sir. Continue.
So maybe within 5 to 7 minutes, I will conclude.
Right.
Now let us come to healthcare system in India. So the concept of healthcare is now clear to you. Now in India, healthcare system is a nationwide system. It is not independent. It is not different in West Bengal, different in Maharashtra, different in Tamil Nadu, not like that. If you visit any state, any union territory, you will find 3 sectors: primary, secondary, tertiary. Primary healthcare, secondary care, tertiary care. What is primary healthcare system? You will find sub-centers, primary health centers, community health centers, or nowadays it is called also block primary health centers. What is a sub-center? If you visit any village, you will find sub-health centers. It is manned by 2, one health worker female, one health worker male, and one auxiliary additional voluntarily health worker. There is no doctor. What is their objective? Mainly to motivate people for immunization, motivate eligible couples for family welfare, etc., etc. So the objective of the sub-health center is to create an awareness among the local community or village community about the existence of healthcare, to utilize healthcare. And not only that, they also perform another job. They promote preventive care. It means that you do this, you do that. Do not take water from the open area. Drink this water, that water, or like that. Take immunization. So preventive care, not curative care. So they promote preventive care. So in plain area, for 5,000 population, there should be one sub-center and hilly and tribal area for 3,000 population, there should be one sub-center. Then we have primary health center. You have heard about it. You might have seen about it. Seen the primary health centers in villages. So for 30,000 population in plain area and 20,000 in hill area or tribal area, there will be a primary health center. And in primary health center, you will find one doctor. So primary health center is the first contact point between a village community and a doctor. And they have other paramedical staff, nurse, auxiliary midwife, then pathologist, etc., etc., etc. Then you have community health centers or block primary health centers. For 80,000 population in hilly and tribal area, and for 1,20,000 population in plain area. And in primary community health center, you will find 4 medical specialists and many paramedical staff. In primary health center, you will find 6 to 8 bed for admission. In primary community health center, you will find 30 bed. So it is like a village hospital. Now, under the secondary care, there are subdivisional and district hospitals. Very clear. We have district hospital at Cooch, but if you go to Tufanganj, Dinhata, you will find subdivisional hospitals. If you go to Mathapanga, subdivisional hospital. It is primary for them, but in this hierarchy, it is secondary, subdivisional and district hospitals. At the tertiary level, you will find medical colleges. Now you will find one in Cooch Behar and in the near Siliguri, North Bengal Medical College and Cooch Behar Medical College, and other super specialty hospitals. These will come under the tertiary category. So all these belong to the public healthcare system, means government healthcare system. There are private sources of care, many private hospitals, private practitioners, etc. There is no category, you cannot categorize them. But the public healthcare system in India, throughout the country, for all the states and union territories, you will find this structure. It is very well defined. And as you see, in case of COVID-19, before COVID-19, how many people visited public healthcare system? Only people at the bottom in our society, they used to visit. But nowadays, everybody is relying on public healthcare system. And public healthcare system has done a very, very good job to tackle this problem. Private sector has also done, but mostly people relied on the public healthcare system. So there is a need to study the problems of the public healthcare system or problems associated with the healthcare system very carefully. So I am encouraging you all that you continue your study in an university, in economics department where health economics is available, and so that you can continue your research with health or healthcare. And then system of medicine. What is the system of medicine? I told about you earlier that we do not use drug. If I take one pill, it will be termed as drug in health economics. But medicine means system of medicine. What is that? In India, we have allopathy in the mainstream. Then we have Ayush. What is Ayush? We have Ayurveda. We have yoga, naturopathy and yoga. We have Unani. We have Siddha. And what is left? Homeopathy. We have Ayurveda, homeopathy, naturopathy and yoga, Unani and Siddha. So in total we have 6. In India, there are 6 different systems of medicine, official. Allopathy in the mainstream, then homeopathy, Ayurveda, naturopathy and yoga, Unani and Siddha under the Ayush. So whenever the medicine, the concept of medicine implies the system of medicine. Obviously, you have no choice. You can select that which system of medicine you will utilize. Once you choose the system of medicine, then you do not have any choice. Then whatever will be prescribed, you have to consume it. But before that, you have a choice. You can select from any of these six system of medicine. But for your information, for all maternal care and for all conditions under the category 1, only allopathy is permitted in India. Homeopathy and other systems are not allowed. Please keep in mind. So I think that I have taken much time. So you may feel bored. If you are interested, then I may come again and I may talk to you or interact with you with more detail. But let me stop here.
Definitely, sir. Definitely, we will try to arrange another program, and we will try to get you in physically here in our college. Thank you, sir. Thank you for your thought-provoking and engaging lecture. Now, I would like to start the question answer session. So, I am requesting the students, the participants, that if you have any question, then you can ask. As I can see that there is no question in our chat box. So, if you have any question, you can ask directly to our guest speaker, sir. Okay, I have got one question. What is the difference between disease, illness, and morbidity? So, Rasika Bhuria, she has asked one question. That what is the difference between disease, illness, and morbidity? Does there have any difference?
Disease is classified. So you have very wisely asked this question. Now Google one term, that International Classification of Diseases, WHO, World Health Organization, they publish almost every year or in a regular interval, that ICD, International Classification of Diseases. So that is disease. What is illness? I am feeling pain in my chest. It is not a disease, it is illness. Or you can say you are a morbid person. But I do not know whether I am feeling pain from the fracture in bone here, or I have a congestion in the chest, or I have blockage in heart. I do not know. So it cannot be categorized as disease at this stage. I am feeling pain. This is my problem. This is my illness. I am ill. I am morbid. But if I go to a doctor, he will or she will diagnose it. She or he will diagnose it as a disease, and then you may classify it according to the classification, latest classification. Maybe ICD-11 round is there, so you can check it. International Classification of Diseases. So what disease will be diagnosed? It will be treated equally in all over the countries who share the views or who agrees with WHO.
I think Rasika has got her answer. So there is no more question in our chat box. Without wasting much time, as we are already going beyond the scheduled time, so now I would like to request Dr. Firoze Hasan, Assistant Professor, Department of Economics, Behar College, to start the procedure of vote of thanks. Firoze, sir, please.
Thank you, sir. Our special thanks to Dr. Pankaj Kumar Devnath, Principal of Cooch College. Thanks to Dr. Amlan Majumder, HOD, North Bengal University, to deliver a special lecture to our students. It is very helpful to us. We will try to arrange such type of program in near future. Thanks all the faculties of Department of Economics, Department of Commerce, and Department of BBA, and thanks all the students to participate and listen very sincerely and carefully to the lecture of Dr. Amlan sir. Okay, thanks, and over to Suman sir.
Thank you, Firoze, sir. Again, I want to mention that our feedback form has been shared in the chat box. So students are requested to please give your valuable feedback and record your attendance. So we have reached at the end of the program. Thank you all for being with us. Thank you, Amlan sir, for accepting our invitation and giving our students to get connect with you through this online platform. Now here principal sir is with us. I think principal sir is with us. So principal sir, are you here with us? Okay. Okay. Now, taking permission from the chairman, I would like to declare the end of the program. Thank you all. Thank you for being with us. Amlan sir, দারুণ খুব ভালো লাগলো।
ঠিক আছে, thanks everyone. So may I leave now?
Yes, sir. Yes, please.
Thank you, sir.